So our next speaker, Dr. Ben Liebwohl, received his MD from the Columbia College of Physicians and Surgeons in 2003, and then completed his internship, residency, and chief residency in internal medicine at Columbia University. He stayed at Columbia as a fellow in digestive and liver disease, during which time he obtained a master's in patient-oriented research from the Department of Biostatistics at the Mailman School of Public Health. He was a postdoctoral fellow in a National Cancer Institute-funded training program in cancer-related population sciences. He joined the faculty of the Celiac Disease Center at Columbia University in 2010. Dr. Liebwohl, thank you for joining us today, and welcome.
Thank you, Mark. And I'm so delighted to be here. I'm just going to share my screen. I think I need great.
Okay.
And before I get started, I want to thank the CCA for inviting me, and not only for today's conference, but for really all the good work that the CCA does throughout the year in terms of science-based medicine and guidance and advocacy. They're really doing good work. And so hats off to the CCA, and thank you for including me in today. I'll be discussing this topic on the diagnosis of celiac disease, and I'll be spending most of the time on the current standard, but also some debates about whether that standard should be changing. The typical way that the diagnosis of celiac disease proceeds in medical textbooks is not always the way that it happens in real life. But this is how we think it should, in general, happen. It starts with a clinical suspicion, and then someone checks antibody levels. And if those levels are elevated, the patient proceeds to an upper endoscopy with a biopsy of the small intestine. And if that biopsy shows characteristic findings of celiac disease, the diagnosis is clinched, it's confirmed, the gluten-free diet is begun. But as you can imagine, in this schematic of someone skipping along this path, there are multiple steps at which one could slip through the cracks. And that is one of the reasons that we have undiagnosed celiac disease, false negatives. And then we also have a problem where people are being told or believe they have celiac disease when in fact, perhaps they don't, false positives. Now, because this process starts with antibody tests, I would like to go over that briefly. If you only remember one antibody that's crucial to check, if you're a primary care physician provider that wants to check for celiac disease, the tissue transglutaminase IgA has the best performance characteristics overall. When I lecture to the trainees at Columbia in New York, I say this is your desert island antibody level. If you can only take one related to celiac disease that you can remember, it's this one. Now, its sensitivity and specificity are listed here, but more on that in a couple of minutes. I want to go over what exactly that means, because whenever we discuss performance characteristics or how good or accurate a test is, one often hears these terms, and they're thrown around in a way that sometimes allows us to skip over what really those implications are. In people who have a low total IgA level, this antibody test may miss such patients. IgA is one kind of antibody that circulates that we all make, except for the perhaps 2% of the population that has selective IgA deficiency. And or probably a little less than 1% of the population, rather. Now, that is a very mild form of immunodeficiency. Most people who have IgA deficiency don't know that there's any issue with their immune system. They live normal, healthy lives. Some of them may be more prone to frequent upper respiratory infections, sinusitis, and other kinds of infections. But the reason it's relevant here is that if people don't make IgA because they just don't produce that class of antibody level in their body, the TTG-IgA blood test for celiac disease will come out normal or negative, and someone with celiac disease would have a negative or normal result. For that reason, there are IgG antibodies that are available. And the two major ones that are in widespread use are the deamidated gliadin peptide, IgG, and the tissue transglutaminase, IgG. Neither of these are as accurate as the tissue transglutaminase IgA in general, but they are very handy in people with selective IgA deficiency. Unfortunately, because of that complexity, often people order an entire panel and we can get isolated, elevated IgG antibodies that are most often a false positive and can lead to confusion and even in some cases, false diagnoses. Now, if the antibody level is elevated, the standard next step is to proceed to an upper endoscopy. That's where the long flexible tube, the fiber optic endoscope, is introduced to the mouth and reaches the small intestine, the first part of the small intestine, the duodenum. And there are certain appearances of the duodenum that we're more likely to find in celiac disease. Shown on the left is a normal appearing duodenum. You see these glistening folds. And shown on the right, these folds have these little divots in them. It's called scalloping of folds. But actually, both of these images are of people with celiac disease. And one common misconception among physicians is that people with celiac disease all have abnormal appearing duodenums during upper endoscopy. In fact, the most common appearance of the duodenum during upper endoscopy is in people with celiac disease is normal. For that reason, if celiac disease is suspected, it's crucial to take a biopsy, small sample for examination. Shown here are another couple of images from a patient with celiac disease. This again is the small intestine, but here you can see a relative absence of those ridges, of those folds. They're much fewer in quantity and in how sort of ridged they are. It's another characteristic finding of celiac disease. But the diagnosis is typically clinched with a biopsy. Now, on the left is a normal appearing duodenum under the microscope. This long finger-like projection is what's called a villus. We have many millions of these in our small intestine, and they maximize the surface area of the small intestine. In celiac disease, the villus has an abnormally high number of immune cells in its wall, essentially responding to dietary gluten and then causing damage. And then shown on the right is what it looks like in celiac disease, where you no longer see these villi, these finger-like projections. You see a flattening of the intestinal wall. These changes can be subtle, or these changes can be obvious. When they're subtle, they might be missed by certain pathologists. Shown here is a schematic of the different patterns. Shown on the left, 0, that is a normal appearing duodenum. Shown next to it, the infiltrative or Marsh 1 type of biopsy result. Most people with that result do not have celiac disease. It is perhaps an early stage of celiac disease, but it also is what we call to be a non-specific change. Many healthy people have a duodenum that looks like that. Only later, when we get to the flat destructive or Marsh 3, all the way on the right, are we more confident that this change specifically is related to celiac disease. So how do we go about testing for celiac disease? Physicians often rely on algorithms, and shown here is the most recent US-based guideline from the American College of Gastroenterology, and they divide patients into high probability or low probability patients. Are we fairly suspicious that this person has celiac disease, or are we less suspicious? The high probability shown on the left, according to this guideline, is a kind of patient who you're so suspicious that you don't even trust the blood tests if it's normal or negative. You go straight to a biopsy. And if you have a positive biopsy, then you've got celiac disease. And if the biopsy is not positive, then the patient does not have celiac disease. And if there's a disagreement, then that often requires further evaluation. Shown on the right, I would say, is the more common scenario where we have some suspicion, maybe based on some symptoms. And we start with the TTG IgA antibody, and we test a total IgA level. If the TTG IgA is positive, that person screened in and they should have a biopsy. And if that biopsy shows celiac disease, it's celiac disease. If the TTG IgA is negative or normal, and the patient makes total IgA, in other words, that patient does not have IgA deficiency, that's a negative test result. Celiac disease is unlikely, and the workup stops there. If, however, the patient has a low total IgA, or an undetectable IgA, in other words, they have selective IgA deficiency, then we check these other antibody levels, TTG-IgG or deamidated gliadin peptide, IgG. So this sometimes can get a little bit complicated. And complicating things further is the fact that there is a movement afoot, now more than 10 years old, for skipping the biopsy entirely. This first emerged in about 2012 by the European Society for Pediatric Gastroenterology, Hepatology, and Nutrition. And these were a set of guidelines that recognize the fact that if the antibody levels are sufficiently elevated, it is so predictive of celiac disease that perhaps the biopsy could or even should be skipped. They initially said that this should only happen among children who have symptoms, and that's the reason they're being tested, as opposed to a child who feels perfectly fine but is being tested because of a family history. But in 2020, they revised the guidelines and they said even for asymptomatic or children free of symptoms, you can go down this pathway. They used to require genetic testing to corroborate the diagnosis. They no longer require it as of 2020. Basically, they say that if the TTG-IgA is greater than 10 times elevated over normal, and on a separate blood draw, the endomysial IgA is elevated, then you can skip the biopsy and celiac disease is confirmed. This is applicable to a minority of children with celiac disease. Most people with celiac disease, and most studies at least, have found that children's antibody elevation is short of those 10 times greater than elevation. And certainly, according to these guidelines, an elevated TTG-IgA, just at any elevation, is not good enough. It has to be greater than 10 times elevated. So let's talk about these test characteristics, because if we're thinking about moving towards relying on blood tests, it's really important we define our terms. When you hear about TTG-IgA, that best test, and you hear 90%, 98%, what does that mean? Well, they're referring to the sensitivity and the specificity. The sensitivity is the proportion of people with the outcome, with celiac disease or with any kind of outcome, who have a positive or abnormal test. The specificity is the proportion of people who don't have that condition, who have a negative or normal test. Now, this is really hard to keep track of when just discussing definitions. I like to think in terms of examples. So if you have a smoke alarm that is constantly going off, every time you turn on the stove to do anything, your smoke alarm goes off, that is an overly sensitive smoke alarm. It has a high sensitivity. In other words, it's not going to miss a fire. It'll never miss a fire because it's always going off, but it has a low specificity. Among scenarios that are not a fire, it does not stay quiet. It's always going off. So that is too sensitive, high sensitivity, low specificity. And you'll see whenever you think about a test, there's a trade-off that if you increase the one, you decrease the other. So we made this smoke alarm way too sensitive, and it's at a cost of specificity. It's always going off. Well, what about the opposite? Something that's very highly specific, but not sensitive. My spam folder is like that. So when I look at my spam digest, if I ever venture inside that spam folder, it's all spam. It's really specific for spam. It does not quarantine or sequester like important messages, or if my friends or family email me, it doesn't end up in my spam folder. It's highly specific. If I go in there, I'm pretty sure that's real spam. But it's not sensitive. I still get plenty of junk in my inbox. My spam filter is highly specific, but not sensitive enough. So those are the two terms you most commonly hear, but what we really want is the positive predictive value. Among those who have an abnormal or positive test, how many actually have the condition? So in plain English, this patient has an elevated TTG-IgA level. What is the chance that she has celiac disease? That's really what we want to know. The positive predictive value. If you have an abnormal test, do I have celiac disease? Yes or no? And here's the thing about test characteristics. The positive predictive value is often what you want to know when you're looking at a test result, but you don't have that. Instead, when you're looking at how good a test is, you'll have the sensitivity and specificity. And what's crucial is that the positive predictive value depends on more than the sensitivity and the specificity. You need to know the prevalence of the disease, how common the condition is in the first place. And this is something I tell the medical students is one of the most important things to learn in medical school, because it applies to any medical test, not just in celiac disease, but any result you get. If you know the sensitivity and specificity, you need to stop, think, and say, what was the chance of this person having the condition in the first place? Because you need to plug that in order to get what you want, which is the positive predictive value. So let's go back to that, right? The tissue transglutaminase IgA. Sensitivity is 90%. It will catch 9 out of 10 people with celiac disease. Specificity is 98%. It will be appropriately negative or normal in 98% of people who don't have celiac disease. So we can actually calculate the positive predictive value. Let's take a general population. And many studies suggest that the overall prevalence of celiac disease in general population is about 1%. So take 1,000 individuals. 1% of them are going to have celiac disease. That's 10 people. Now, 10 will have celiac and 990 will not have celiac disease. If the sensitivity of the TTG is 90%, that means of those 10 people with celiac disease, the TTG will be elevated or positive in 9 out of 10. Among the 990 people who do not have celiac disease, the TTG will be appropriately negative in 98% of them, or 970 out of 990. But what we really want to know is the positive predictive value. So how many people have a positive TTG of these 1,000? 9 plus 20, 29, and 9 out of the 29 will have celiac disease. The positive predictive value is 9 out of 29, only 31%. This is one of the reasons why we don't just screen everyone for celiac disease in the general population. The positive predictive value is unacceptably low. And if you don't know about this trade-off and this principle, when you hear sensitivity 90%, specificity 98%, you might say the false positive rate is so low. In fact, it's very high. Most people just screened, unselected, who have any TTG-IgA elevation, only 31% will have celiac disease. But everything changes if you're testing a different group. Let's say the population prevalence is not 1%. That's the general population. Let's say it's 10%. That is the population of people who have a family history of celiac disease in a close relative. If your mother, father, or sibling has celiac disease, your lifetime risk of celiac disease is about 10%. If you then plug in the numbers again, suddenly the positive predictive value of any elevated TTG shoots up to 83%. So it's all about the underlying prevalence, how common the condition is in the population in the first place among the people getting tested. So what about the positive predictive value of highly elevated TTG-IgA levels among adults? Because these pediatric European guidelines suggested that perhaps the biopsy could be skipped. Well, here at Columbia, we participated in a multi-center cohort of 8 countries, 11 different endoscopy groups, and there were 42 adults who had a highly elevated TTG level. 40 out of 42 had the biopsy findings that were clearly convincing for celiac disease. The positive predictive value of a 10 times elevated tissue transglutaminase was 95%. Is that good enough? Well, it's something that we can certainly tell patients who are thinking about skipping the biopsy. We can say, one small study, multi-center, but fewer than 100 people with this kind of elevation, 95% of them have celiac disease. The NNH is the number needed to harm. In other words, if we were just to tell people, you've got celiac disease, start the diet, 5% or 1 in 20 don't have celiac disease necessarily, and we're telling them to be on a long-term strict gluten-free diet. So I don't know if that's high enough. I personally would want to be closer to 100% sure. There's also some concern that some diagnoses might be skipped during the upper endoscopy. If we skip the endoscopy, we might miss certain kinds of gastritis or esophageal disorders. And skipping the biopsy might pose management difficulties in the long term. If someone skipped the biopsy initially, they feel better after they start a gluten-free diet, and then 3 years later, they start feeling ill, and they're on a strict gluten-free diet, and then we take a look, we do a biopsy, then everything looks normal. We don't know if everything looks normal because they have well-treated celiac disease with, some other cause of their symptom, or maybe they never had celiac disease to begin with. There's also a problem of over-relying on these non-TTG IgA antibodies. They can be very useful sometimes, especially in selective IgA deficiency. But when they're elevated in isolation, in other words, they're elevated, but the other ones are normal, most people with that combination, they don't have celiac disease. If you have any deamidated gliadin peptide positivity, and then you undergo a biopsy while eating gluten, the chance that that's celiac disease is 15%. So certainly greater than someone from the general population picked from chance, but the majority, 85%, don't have celiac disease. So it's certainly not appropriate to rely on just one of those antibodies without confirming it with a biopsy. But I acknowledge there is a debate, and you're probably hearing that I'm a believer in biopsy for adults, and I am. But what's the current state of this debate? In Europe, the biopsy-free diagnosis is offered by guidelines. It's got that seal of approval. It's part of standard of care for children, and it's increasingly gaining acceptance. The British Society of Gastroenterology actually includes skipping the biopsy as an option, even for adults. This came about during the lockdown periods in COVID, when we really wanted to minimize in-person interactions, even with healthcare practitioners, if possible. And so they offered this way to skip an endoscopy if certain criteria were met. Now, whether this will sort of be the law of the land in Britain in the aftermath of COVID is unknown, but these are out there. In North America, there are no biopsy-free guidelines for children or adults, period. There's no guideline that says you can skip it. And yet it is certainly happening. It's happening more in children, to a less degree in adults. In other words, guidelines are not being followed, but it's certainly happening for a number of reasons, because getting the appointment for the endoscopy might be a challenge, concern about the actual procedure itself. Why go through with it when I'm pretty sure it's celiac disease? I want to get well now. I want to start the diet now, or no one told me it was necessary. I've already started the diet. I will say it is happening, but it's not always ideal. And this really poses a dilemma in the era of clinical trials of therapies. There are all these therapies now being tested in various phases of development to treat celiac disease. And nearly all of them say you need to have celiac disease to qualify for the study. And that has to be a biopsy-proven diagnosis. And so what about non-biopsy diagnosed patients? What about a 21-year-old who was diagnosed without a biopsy in Europe when he was 16? Would that person qualify or not? For many protocols, they'd say no. And so that's an issue. Or what about an adult who skipped the biopsy, even though they had a very highly elevated TTG IgA? And I can look them in the eye and say, there's a 95% chance you've got celiac disease, and I'll treat you like you've got it. Should they be excluded from a trial? Or if a trial is successful and that drug is approved and available, would an insurance company approve for that to be prescribed for someone whose diagnosis was not confirmed by a biopsy? So I think that we need to really consider that in this era where people are skipping the biopsy by means of guidelines or not. I should mention, just before closing, there are other debates surrounding diagnosis that are frankly beyond the scope of this presentation. In other words, who to test in the first place remains an area of some uncertainty and of controversy. And then what about screening for celiac disease in people who feel perfectly fine, have zero symptoms? Is it worth getting them diagnosed, biopsied, and putting them on the gluten-free diet? I imagine that many people in this forum would say, of course, untreated celiac disease can cause harm. And I agree with that concern. At the same time, taking someone who's perfectly healthy and giving them this diagnosis and diet, which can be difficult, has its own challenges. And we don't have definitive long-term evidence that taking someone who felt fine in the first place and putting them on a diet after a diagnosis makes them better off. Most of the long-term studies we have include people who felt ill, had some problem, whether it was as children, they had growth or development issues, or as adults, they have many of the different kinds of symptoms or signs in celiac disease. So there is a little bit of debate about screening for people who feel perfectly fine. Finally, I just want to raise your awareness of this organization. I'm the president of the Society for the Study of Celiac Disease. It's a professional organization. It's for physicians, dietitians, scientists, allied health professionals in this field. Our mission is to advance this field and focusing on understanding of the immunology, on diagnosis, and on treatment. We have a webinar series that you can get from our website, theceliacsociety.org. That webinar series that focused on clinical trials was done earlier this calendar year. That is free to the public. We also have quarterly webinars that's for members only, and our next one is coming up later this month, which is going to be about the best of Sorrento. We've given out travel awards for trainees and young investigators to present their research at national or international meetings. And we give up grants and collaborate with others for grant opportunities. So I thank you for your attention, and I look forward to taking your questions.
All right. Thank you very much.